We continue our study in injury and illness to the central nervous system, and we study specifically the mechanism of injury that is called TBI, or traumatic brain injury. And traumatic brain injuries can be categorized as coup, direct injuries, contra coup, which is where the brain is pushed back against the opposite side of the cranial vault and injury occurs to that portion of the brain. And then rotational traumas can result in brain injuries, as in someone being hit in the chin, as in cage fighting, and there's rotation, and that can lead to immediate unconsciousness and brain injury. Certainly fractures to the skull can be one of the classifications, and penetrating traumas to the wound. Right here is a gunshot wound to the posterior portion of the skull. Another classification for all of these would be closed versus open. Now, the PowerPoint presentation is available to you on E-Class. I have some of these that need to be filled in, and I would recommend for this presentation that you have your PowerPoint open as well, or print it out and have it available to you. You'll need it probably down the line for study purposes. And then head injury, the frequency of head injury has to do with the specificity of ages. And so filling in the blank, ages 1 to 2, injury to the brain is a result of child abuse. Shaken baby syndrome, where someone, out of lack of control of their own emotions, perhaps is not able to see the baby's crying for what it is, and picks the baby up and shakes the baby. Can you see coup and contra coup, action and reaction, can lead to brain injury of that little pup. And then ages 15 to 24, males are at very high risk from being wild at heart and taking chances. Now, that doesn't necessarily leave out women who are adventurous, but this is a period of time where fast cars, jumping off of, doing a stunt with a skateboard or a bike, or taking chances leads to injury to the head. Accidents, okay? Certainly this is a period of time where people are experimenting with alcohol, and that changes perception and lowers inhibition, such that risk can be taken. And then in the elderly, because they become less stable, their neuromuscular coordination and their efficiency, the ataxia that's present, not capable of doing meaningful movements, they have a tendency to fall and don't fall appropriately, dissipate the force over time and area, and they're vulnerable to head injury as well. Most frequent etiology of head injury is car accidents. Alcohol intoxication is involved in 50% of the emergency room traumatic brain injury admissions. And then secondary brain injury, I want you to be alert to. Once a brain injury occurs, there are secondary events that have to do with reduced circulation in the brain, and that would have to do with swelling and perfusion of the tissues. So increased pressure in the cranial vault ultimately exceeds the arterial pressure, and oxygenated blood cannot get to the brain. That's a possibility. And then impaired perfusion, where there's not enough uptake of oxygen. And when the circulation is impaired, necrosis will occur. Okay, avascular necrosis, not enough oxygen being delivered to the brain. Treatment of head injury includes anti-inflammatory pharmacopoeia to reduce the immediate threat of inflammation early on, hyperventilation, increasing the amount of oxygen that's delivered. 16% of the ambient air is oxygen. This can be ratcheted up. Person can be on at 100% oxygen with the hopes that more oxygen is disseminated or perfused in the brain. Hypothermia, if we drop a person's body temperature, their metabolism will go down. The demand for oxygen is reduced. Inducing a coma, likewise, if we keep them quiet, sometimes in head trauma, it leads to a hyperactivity, increased metabolism, and by putting them in an induced coma, that's forced rest for the central nervous system. Elevating the head, and if pressure gets so great that the cranial vault will not yield, then a craniotomy may be necessary to relieve the pressure to allow more blood to get into the area. We've talked about the Glasgow Coma Scale, the levels of consciousness provided there again. I've provided Terry Schiavo's case in a YouTube video that demonstrates persistent vegetative state, the ethics of allowing a person to die who somewhere is lost between persistent vegetative state and a coma. This was lived out in the life of this young woman, and I'd like you to know about it because it will influence your value system for when there ought to be action taken or action not taken to preserve a life. Okay, Glasgow Coma Scale, make sure that you're internalizing that. Don't need to say anything more to you about that. Now, the cranial nerves, you've studied the cranial nerves. You know that if we take the brain and look at the base of the brain, the 12 pairs of cranial nerves are manifested for you. I'd like you to come to Tuesday's class reviewed on the cranial nerves, because we'll be doing a project with a life-size brain, and I want you to be able to fabricate or create cranial nerves, naming the cranial nerves, and then we'll move into an on-the-field use of an evaluation of the cranial nerves. It's an abbreviated form where you don't go cranial nerve 1 through 12. You lump them together and have shared, or it's just way efficient to do. So the best way to be ready for that is to review your cranial nerves and what the textbook approach is to evaluating each, and then we'll show you that you're saving time by doing the field testing. Concussions are insults to the brain. Very often they're blunt trauma, could be from a blast or from forces that are axial or rotational, acceleration, and really rapid deacceleration can end up traumatizing the head. The American Academy of Neurology and the American Society of Neurosurgeons have the very most developed schemes for assessing. Also, the Cantu style is cited by the AAN. In this day and age, the realization that each concussion can manifest radically different. We would grade out someone at a mild using the Cantu system, but their post-concussion syndrome or symptoms could persist over weeks. And the big deal is that if a person has blurred consciousness or worse, then we need to do on-the-spot testing to determine if there's cranial nerve injury, there's sensory motor deficits, if there's cognition problems, balance problems, and again, we'll do the on-field testing for cranial nerve. And until the person is symptom-free, not to go back, not to return, whether that's 20 minutes from now or a month from now. So need to be students of concussion, and I know that's been dealt with in your athletic training class and in your advanced classes as well. Second impact syndrome, I'm encouraging you to go to the graphic in E-class. Second impact syndrome, after a person has experienced a concussion, if they have insult, if they have more trauma to the brain, then it takes very little force for there to be an uncontrolled or a very rapid bleed in the brain, and the person can have increased cranial pressure so rapidly that there's not a surgical correction. Doesn't happen very often, but when it does, it changes people's lives. This happened at University of La Verne. I think maybe it was 6 years ago. A football player had been concussed. Everybody thought he was better. Went back several weeks later, sustained another trauma to the brain, and he didn't live more than an hour and a half after that. And I just know what a terrible circumstance the people who survived, the athletic personnel, the medical personnel, the family, friends, and teammates. You don't want that to happen. So if you're working with people who are doing concussive contact sports, then we need to really make sure that we're up on the guidelines for holding people out of activity until they're cleared. Intracranial hemorrhage really is what we've talked about with a second impact syndrome. This can happen on first impact, but you're very aware that the subdural hematoma is a slow venous bleed. Symptoms will take considerable amount of time, maybe weeks, before the person begins to have difficulty concentrating, balance, cranial nerve manifestation. Contrast that with epidural arterial bleed, and their symptoms will manifest immediately. And if they begin to have respiratory difficulty, they lapse into unconsciousness, that may be a life flight circumstance. We've had cases in the county where football players have had to be life flighted out of a football stadium. You need to be up on top of that. When a brain injury occurs, it could be from injury on the battlefield or any of these other types of brain mechanisms of injury. I want you to be familiar with, if a person becomes injured in their cognitive capacity, there are changes in how they perceive themselves and what their function is. And this is called coping with the new self. It may have to do with their mentation, how they do with paying attention to detail, memory, perception, language, and problem solving can all plateau. It may be that after the concussion or after the brain trauma, they make improvement, but it could be that they plateau at any place and they have personality changes and cognitive changes that result in them being a new self. It's very important to realize, if you're a physical therapist, athlete trainer, or physician assistant, that functional outcomes are limited by cognitive status. If a person is not able to learn how to cope with life, then they're not going to be able to do a home program in physical therapy. Cognitive rehabilitation and physical rehab are closely related, and a person who has significant brain injury needs to have both types of therapy. Okay, bless you. Bye-bye.